now. That would be perfect. And let's go to the next slide. So I'm Amy Maracle. I'm a research scientist in the Alcohol Research Group at the Public Health Institute. I co-lead the I-STARR project with Dr. Carmen Masson, who's a professor of psychiatry in the School of Medicine at the University of California, San Francisco. The team also includes co-investigators Sarah Zemore and Lenny Jason, biostatisticians Meena Subaraman and Leba Lee, and communication specialists Diane Schmidt and Dustin Kebsu. Our project coordinator is Quinoja Capitani. Next slide, please. The I-STARR project activities are also guided by a 17-member advisory board, and our advisory board is comprised of a diverse group of leaders from across the country. So most advisory board members wear many different hats, but as a whole, they represent recovery housing and recovery leaders, treatment providers and payers, national policy advocates, as well as researchers and educators. Some of our advisory board members may be in the audience, but many of them also serve as presenters in this webinar series. Let's go to the next slide, please. So before I introduce the presenter for today, we do want to get some information on who we have in our virtual audience. So we'd like to do some polling. There are just 3 questions in this poll. The first question is basically who you are. We're also curious about how you would answer these 2 questions. One about historic barriers to collaboration between MOUD prescribers and recovery housing, and also one about value-based payment models. So if we could launch the poll now, that would be great. And although there are only 3 questions, you may have to scroll down to see all 3 of them, and Zoom won't actually let you leave the poll until you answer all the questions. And once we get a good 70 to 80% of folks responding to the polling questions, we'll review the results of the poll. Oh, I'm just seeing in the chat that folks can't see the poll. We need to launch the poll again.
Let me try to relaunch.
Okay, we're going to relaunch the poll. All right, hopefully folks are seeing it now. Thanks for your patience, folks. Justin, where are we at with the polling results?
We just hit 70%.
Here we go. Excellent. Hopefully folks can see the polling results. I'll just review them briefly. So it looks like over half, or 53% of the folks who are on the call today are recovery residents, operators, owners, or other staff. We have a large percentage of folks who answered the question about historic barriers as all of the above. It's split between, in terms of the value-based payment models, responses between outcomes and don't know. Well, I think that because of the topic of our presentation, covering both a discussion of barriers and the topic of value-based payments, that this should be really helpful and hopefully engaging for all folks who are here today. So let's go to the next slide. And without further ado, I do want to introduce today's presenter, which is Jason Howell. So Jason is a person in long-term recovery from mental health and substance use issues. He has an MBA from Texas A&M University and is a recovery support peer specialist and supervisor. Jason is the executive director of Recovery People, which is a 501c3 nonprofit that engages, educates, and empowers change makers to use their lived experience to help others affected by substance use and related mental health challenges. He's a founder and a former board president of the National Alliance for Recovery Residences, or NAR. He's also a national speaker and has co-authored several articles published in peer-reviewed journals. And with that introduction, let's go to the next slide. I am pleased to hand things off to Jason, who will provide an overview of collaborating with prescribers of MOUD. Thank you, Jason.
Yeah, thank you, Amy, and thank you for inviting me back. I really am glad that we're having this conversation today, talking about the relationship between recovery housing providers and prescribers. And we have this title, Friends or Foe. It's a little provocative, but we did that intentionally because I think a lot of us can easily fall into that trap. And we're going to talk a little bit more about that and then how to overcome it. So if we could go to the next slide. So again, this a mindset of friend or foe, it's common thinking, but it's not really helpful, especially when we're wanting to support individuals on their recovery journey, including taking medication as part of that recovery journey. In the psychological world, they oftentimes refer to this as splitting, and we'll spend a little time to talk about, what is splitting, why it might happen, and then move into, what are some ways that we can move past it. Next slide, please. So when people refer to splitting, they are talking about this tendency to view things in extremes. So good or bad, black or white, all or none, friend or foe. I will admit that I have fallen into that trap, that thought process. And I've learned not to judge myself. It's just more of like, now I bring some self-awareness to it. And with that self-awareness, then I can be more in charge or have an opportunity to change that mindset. So with the next slide, we'll take a look at why this thought process might happen. And it can be a coping mechanism. It's a common defense mechanism used to make sense of an experience or cope with overwhelming emotion. And I think for me, when I find myself moving into this black or white thinking, friend or foe thinking, it's because I haven't fully processed what's going on, or maybe my values are being bruised a little bit or not feeling fully heard. And again, this is just not very helpful if we're thinking about how can we work with prescribers to really support individuals in recovery. So if we could go to the next slide, here are some ways that we could move past it. I've listed a few here, and I'm sure y'all could list many, many more. But probably one of the most powerful things is, how do we rally around our common interest? And we'll take a look at, there are several common interests that prescribers and recovery housing providers can have. And then beyond that, looking at how do we build trust or rebuild trust by honoring multiple perspectives, looking for opportunities to educate each other, educate ourselves, as well as empower the individuals that we serve. Those residents are from the prescriber's perspective, their patients or clients. And then finally, we'll talk about, when we work with prescribers and develop this trust, how can we do it in a professional, legal, and ethical way? All right, now that we've got that framework let's move to the next slide and start talking about rallying around our common interest. And I've listed 3 ways here. One, we can take a look at how we each or together can increase clinical outcomes or recovery outcomes. Third, we'll talk a little bit about how recovery housing can lower cost and how that might be of interest to our prescribers. And then third, this may be the biggest leverage or mechanism for change, value-based payment models. And I know that was one of the polling questions. Some of you were familiar with what that term means, others weren't. And so we'll spend some time talking about what is value-based payment models and why that might financially incentivize prescribers and recovery housing providers to work well together or collaborate. Next slide, please. All right. So, I think that prescribers, just like recovery housing providers, we gravitate to this work because we really want to support individuals, it's individuals along their recovery path. And so realizing and highlighting that recovery housing can, increase clinical outcomes that can look like, lowering overdose and lowering mortality rates. I think that is something that we can highlight and have in common with prescribers. We can also look at recovery housing's ability to improve mental health, improve recovery capital. And when I say recovery capital, I'm talking about those internal and external strengths and assets that we use to build upon our recovery and build resiliency. Recovery housing, we can frame it in the context of improving one's quality of life, our residents' quality of life. And that includes those pro-social bonds that they're forming within recovery housing. And then that naturally leads us into this conversation about social determinants of health. And you may have heard more about social determinants of health over the last couple of years. In some areas, I know in Texas, you'll hear the term non-clinical determinants of health. It means the same thing, but slightly different phraseology. It highlights that we're talking about, non-clinical, aspects of one's environment that support recovery. I've come to understand that recovery is a person-driven process, a person-centered process, but it happens in the context of an ecosystem and in context. And that's another way to look at social determinants of health. And recovery housing does an excellent job at, again, looking at providing a strong recovery-oriented social network, supportive place to live, encouraging people to get employment, and all these elements of social determinants that prescribers will be looking for, because that's not something that they do. And so this opens the door to a conversation about how prescribers and recovery housing can work together, because we're really helping individuals in different and synergistic ways. All right. Next slide, please. Lowering cost. So this is another advantage that recovery housing can provide, so a benefit that you can highlight in your conversation with prescribers. Earlier we talked about, recovery housing and its ability to, support individuals with opiate use disorder, decrease overdose. Well, that quickly translates, excuse me, into decrease in hospitalization rates, decrease in individuals needing to access very intensive and costly services. And so the other cost-saving mechanism that we can highlight, and this is definitely been researched, especially in Oxford House, is the decreased cost in criminal justice involvement. There's a couple of different great economic studies done on Oxford House that looked at cost savings, and much of the cost savings was as a result as individuals living in Oxford House, I believe for at least 6 months, had a threefold decrease in their likelihood of being re-engaged with criminal justice and all the savings that come with that. So now that we've talked about improving clinical and recovery outcomes, as well as lowering cost, that's a natural bridge for us to start talking about value-based payment models. So if we could go, thank you. So as our system moves to value-based payment models, away from fee-for-service towards value-based, recovery housing is going to become more and more relevant because, as we've just talked about, recovery housing can improve outcomes while lowering cost. You know, historically in the United States, the way that prescribers and a lot of healthcare providers have been compensated, financially incentivized, is for fee for service. And so it's an output. It's you know, a day in treatment, a session of outpatient, meeting a prescriber, you know, meeting their patient at their office. That all is an output, and they would you know, bill insurance and receive a fee for that output. So that's the fee for service model. And although it's has many advantages, some of the things that it could do is stimulate overutilization and really not have an eye towards the best outcome for the patient. So we definitely see, I think it's CMS, the Center for Medicaid and Medicare Services, has announced that by 2030, they're moving 100% to value-based payment models. And we see commercial insurance kind of following that lead. So when we move to a new paradigm that looks at, you know, compensating individuals in a value-based perspective, that looks like groups of service providers coming together, all thinking about how can we increase the outcome of individuals at a lower cost. Well, we've all known that if you can get somebody in recovery housing, they're less likely to need to go back into some of the higher, more intensive and more expensive services. So that's going to increase outcomes and lower cost. So as recovery housing starts being welcomed into this group of service providers, we can play a really important role and financially incentivize individuals, prescribers, for referring their patients into recovery housing. All right, next slide, please. So we're moving to kind of the next area that I've outlined, you know, how we can build trust, rebuild trust, and kind of overcome this splitting friend or foe mindset. And it's about honoring multiple perspectives. We all come with different perspectives, and two things can be absolutely true at the same time. And two examples that I'm going to provide here today is we're going to look at medical model versus social model. And then the other is like, how do we know things and where do we come from that? And so we're going to talk about, you know, an academic lens versus a lived experience lens coming towards knowing things. So if we could go to the next slide. So of course, prescribers are trained in the medical model, and the medical model focuses on diagnosis and treatment. And so a prescriber is going to view their patients, diagnose them as having, you know, an opiate use disorder or some other form of a substance use disorder, and then think about, you know, what is the treatment? You know, is there a medication that we could prescribe? Is there another intervention that we should connect individuals with? That's all great, evidence-based. We want that. On the flip side, recovery housing providers, we come from a different perspective. We come from a social model focus. And social model looks at, like I mentioned before, the context that someone's in. We focus in that social cultural element, that ecological impact, again, which can be very important in supporting individual along the recovery path. So it's not an either or, it's a both, an and both. You know, how can we, you know, work with prescribers to make sure that individuals are on the appropriate medications? And how are individuals, you know, accessing those social determinants of health, specifically in recovery housing, so we can work on our side, all supporting these individuals towards greater recovery outcomes. All right, next slide, please. The other perspective, how do we know something? How do we know something is true? How do we filter information? And it can be through different lenses. And it's not that one lens has to be right while the other lens has to be wrong. it is just two different perspectives. And in this case, of course, prescribers are going to be trained from an academic standpoint. So their knowledge base is based on academic theory and research. On the other hand, those of us in recovery, we tend to know things based on our personal experience or the personal experience of others. We learn and view things through story and sharing story and through culture. Again, one's not more right than the other. They're just two perspectives. And how can we bring those two perspectives together to do what's best and right for the individuals that we collectively serve? Next slide, please. All right, let's pivot and start thinking about the educational opportunities as well as the empowerment opportunities. I apologize, my allergies are kicking in, so I feel my voice getting a little raspier as we go, but we're going to power through. So three areas underneath this as, addressing individuals who are uninformed, then addressing individuals who are misinformed or even disinformed. And then the third is around empowering shared decision-making. All right, so let's take a little deeper dive on each one of these. Next slide. So when it comes to people being uninformed, I think it's helpful to understand that prescribers, with the exception of addictionologists, really don't have much training when it comes to substance use disorder. I was at a conference last week. It was the Texas Substance Use Symposium, and I see Richard Hamner on here. Richard, that was a fantastic symposium. It was great job. I really enjoyed it. I got to meet some medical students who were attending the symposium who happened to be in recovery. And so I pulled them aside and said, with the opiate epidemic, with the increase of substance use focus, do we see medical schools adding more to their curriculum about, substance use? And they said no. And I think they were very disappointed and are trying to advocate within their medical school to get more. But just, I think they had mentioned that, well, that they may talk about detox and maybe a little bit about treatment, but very little time is spent. That's on treatment. They likely are not going to hear anything about recovery services or recovery housing. So we're highlighting some opportunities for us to be a resource for prescribers. We also have to remember that even DEA registered practitioners or prescribers are only receiving about 8 hours of training on opiate use disorder, on substance use disorder, and its treatments. That's not very much from my perspective, but at least they're getting those 8 hours. And kind of going back to that symposium, the Texas Substance Use Symposium that I was at last week, one of the addictionologists was talking about how he has seen many prescribers become DEA registered and kind of move into prescribing MOUD, but quickly realizing that they don't have the referral networks, that maybe the 8 hours of training wasn't enough to understand our particular population and our particular needs. So again, this points to an opportunity for us to be subject matter experts and a resource for prescribers. All right, next slide, please. I think we also need to acknowledge that we as the recovery community and recovery housing providers are also uninformed in many ways. We're not required to have any academic training on substance use disorder or much less medications. So there's an opportunity for us to seek out education for ourselves as well as provide an educational resource for the prescribers. All right, next slide. Misinformation and disinformation. What are we talking about here? Misinformation is false information that is spread. It could, regardless of the intent. Maybe it's being done intentional or unintentional, but it's false information. Disinformation is misinformation, but it is definitely intentionally being spread. And we have seen that within the space that we're talking about. That with the opiate abatement dollars, those are for settlements from Big Pharma who actively were spreading disinformation about the risk of some of the pain medications. And so I know that my personal history and going into surgery and talking with my doctors, I'm also oftentimes finding that I'm needing to educate them on medications risk of diversion and addiction. And it all harkens back to them either receiving disinformation or just being uninformed. Yeah. Again, I just want to highlight, we have an opportunity to be an educational resource for them. All right, let's move to the third point, which is about promoting shared decision-making. I want to be clear that as recovery housing providers or recovery service providers, we really don't have any business of kind of getting in the middle and pressuring our residents or doctors' patients about medications. Really, those decisions about medication should be between the patient and their doctor and their prescriber. But if you're like me, you go into a doctor's office, you feel intimidated. Sometimes you put them on high like they're a demigod. And we really wanted to empower individuals in this notion of shared decision-making. We've got some resources that are being dropped into the chat for you to learn more about this. There is an appropriate role for us to kind of bolster and support our residents as they do have these conversations with their doctors. So we can role play with them. We can, just really kind of support them along this journey. Next slide, please. All right, here's the kind of the last pillar that I'm going to talk about. And when we reach out to prescribers and want to engage them and build these relationships, we need to make sure that we do it professionally, legally, and ethically. And I'm going to point out in two areas that to make sure that you do this. One's around privacy and the other's around referrals. So if we could go to the next slide, we'll first talk about privacy. And you may have heard that there's some federal laws out there that all prescribers must legally adhere to. As a recovery housing provider, you may legally be required to, or you definitely ethically should be adhering to these. And it is HIPAA and 42 CFR. There's some resources going into the chat that you can explore, more about that. But we're getting down to privacy. And so if you start talking to your prescribers about a particular individual, you're going to make them uncomfortable unless you've got the appropriate paperwork signed, because they legally can't talk about that individual. You may elicit some response like, I cannot confirm or deny that we are serving, Bubba Jones. By approaching them in this way, you clearly are not being a good partner, and they may kind of retreat or choose not to work with you. So respect their boundaries, respect your residents' privacy, and make sure that you have the appropriate releases signed before you engage in these kind of conversations. Also remember that that's federal law. States oftentimes have more restrictive privacy laws than the federal laws. So do your research, know what your state laws are, and be respectful when around these for various reasons when you approach your prescribers. All right, we'll move to the final slide, and this is about referrals. We've oftentimes seen bad players in the recovery housing space, developing unholy alliances with prescribers and with different treatment providers that were milking insurance. So know that that bad behavior has been out there. I think that we all should be sensitive to that. We definitely don't want to give any kind of indication that we are open to that or leaning into that. So make sure that when you are giving referrals and accepting referrals, that you disclose any and all conflicts of interest, that you steer clear of inducements, kickbacks, patient brokering. NAR has created some ethical policies around that. There's some resources that have been dropped into the chat around that. But again, if we want to cultivate respect and relationships with our prescribers, and there's lots of good reasons too, we need to mindfully do it. And with that, I want to turn it back over to Amy. I know that we've got some more, I think we got some Q&A a little later on, as well as some more programming.
Thank you, Jason. That was amazing. So I was fully prepared to hear about different kinds of barriers, but I really like that this presentation was focused on how to overcome those barriers, how to find common ground. So that was really, really helpful. We've tried to jam in as much as we could within the context of this webinar. My guess is that there's probably a lot that could be said on this topic. So we have tried to pull together some resources for folks who might want to take a deeper dive. So let's go to the next slide. So in this slide, we've highlighted some journal articles and some other tools and resources for folks. We'll drop all of those into the chat, and the ones that everything that's publicly available, we'll make sure that the links are there for folks. Jason, is there anything that you want to say about these resources? Anything that you pulled for or pulled upon or reached for and pulled out that you found was particularly helpful, stuff that you found in your search that wasn't helpful?
You know, and this might be just more of where I'm at in life and my thought processes, but the shared decision-making tools I find very valuable. Personally, as you know, I go into to my physicians and think about, you know, how I am engaged more in shared decision making for myself, and then also thinking about, you know, individuals in recovery, conversations around, you know, MOUD medications, mental health medications. I think just in general, you know, empowering individuals in their own health and their own well-being. And so those are the two that are shiny for me today, and that's why.
Excellent, thank you. So let's go to the next slide. And this is where we want to pause and open things up to folks in the audience. So we've been monitoring the chat if you've been dropping your questions there, but feel free to unmute yourself, raise your virtual hand, because we've got a good 10 minutes for Q&A and for discussion about this topic. And I'm going to hand things over to you, Diane, to facilitate the Q&A session.
Thanks so much, Amy, and thanks, Jason. That was an amazing presentation and just so much information. We don't have any questions right now in the chat, but I'd welcome people to drop anything in. And we have Ralph. Do you want to unmute yourself and ask your question of Jason?
I'm working on starting the video here. Oh, got a delay. Sorry about that. Thank you, and thank you, Jason, for doing this. I have more of a comment around the educational piece of it, which is to educate prescribers and providers what recovery housing is versus what Housing First may provide. Because one of the challenges that we have, and we're involved with the Project Homes, which is exclusively MOUD here in Houston. And we have relationships with a number of the methadone clinics and the providers out there that deal exclusively with MOUD. And the education process has taken a couple of years for them to understand that we don't just open the door and, you know, take in somebody that's still smoking marijuana or, you know, doing other things that are not illegal substances, which, you know, some of them, you know, allow a certain amount of that to go on. So there's been a tension between us and them at times when somebody's gotten expelled for a behavioral reason or returned to some kind of a use of a different substance that they allow that we don't. So I just wanted to point that out as an educational piece.
Yeah, and Ralph, thank you for that comment. And I kind of look to you as a subject matter expert on this because you are on the ground. You are one of the pioneers around, you know, MAT recovery housing and working those prescribers. I do see that. And I think, you know, in my slides, I was trying to hint at that because it's coming from different perspectives. I think prescribers are trained in the medical model. They may be more exposed to concepts around harm reduction, you know, and they may not understand why in recovery housing we create certain environments. If they're focused in on their patient and the person driven versus in recovery housing, we're thinking about, you know, we have a particular environment for a particular population with particular goals, and we're thinking about how do we create a supportive environment for everybody. You know, I do think that there's an opportunity for us to develop some educational materials that does communicate that and bridge.
That's great. Thank you so much, Jason. I have another question in the chat from Steven. He asks, how should we respond to AA and NA groups that don't accept MAT?
Yeah, I think we've all pondered that. I take a particular perspective that others might not. I don't know if it's our place to go change AA or change NA. I think that we have an opportunity to create other mutual aid societies and other groups that are specifically for individuals on MAT. I think that when we get into a place of trying to change a group's culture, you know, I think that there's some iatrogenic, you know, issues that we should think of, and we may not get the results that we want. There has been some studies in recovery housing where recovery homes, where the attitude in the recovery home was not accepting of MAT, but they were forced to accept persons on MAT. And what we found is those individuals discontinued their medication to assimilate into the culture. I think that that could be very similar if we were trying to force a mutual aid group that wasn't really supportive of medication. If we force those individuals in that culture, they're just going to discontinue their medication. And I don't think that that's the ultimate goal. Luckily, in today, there's lots of different mutual aid groups, support groups, and we should be looking at how do we bolster it and replicate those.
That's great. Just along those similar veins, I'm just going to make a comment that Cecilia dropped into the chat. She says, one thing that has been very difficult for use here at TCMC is some detox center who do not allow mental health medications while detoxing. I understand some do have clinical staff. This has created a huge barrier in care for us.
You know, I think because of the opiate epidemic, we really focused in on, you know, medications for opiate use disorder. But as we look at, you know, and some of the previous webinars that at least I've been on, we've talked about how do you address, you know, diversion concerns or shared decision making. I mean, it becomes just about medication. And so if you're developing some protocols and a supportive culture for MOUD, it may be the same for other medications. And I actually find that, I don't know if exciting is the right word, but I find it really helpful for us to, you know, to think about more global solutions.
No, that's great. So this is the last call for any Q&A. This is your chance to ask Jason any questions you have. Take the opportunity.
I have a question.
Sure, Ryan, please.
Yeah. Hi, my name is Ryan Lowe. I work out here in Pine Top, Arizona. Thank you for holding this. It's very timely. I chair a committee that talks about substance use. And one of our questions that we're posing and trying to find ways through this barrier of trying to promote MOUD and MAT services, right? We're looking at trying to figure out maybe unique ways to promote it. It's just not a very well-known thing in this small town that I live in, and so which is wild because it's a small town. You feel like it would be easier to be able to get that information out to the public. Yet I think there's probably a little bit of pushback, it being a small town. So with that, we're talking about education, right? So that's a key thing. And so we're hoping to open up some platforms to be able to educate people on these services. But I was wondering, two questions. One, do you have any unique ideas, or anybody have any unique ideas as to how to educate the community? And then my second question is, when we're talking about training prescribers, we're talking about PCPs and stuff, correct? I mean, that would fall into like primary care physicians and things. Who would do that training? Would that be our local CMS, or what would be the best avenue as far as promoting that training, as opposed to me just going and being like, hey, work for me, and so, we're just trying to find the most effective way to promote it, because it is such an epidemic and people are dying left and right, especially in these rural areas like Pine Top and Winslow area here in Arizona. So those are my two questions, if I didn't get in the weeds too much there.
Yeah. Thank you for that. So I'll answer the second one. I'm actually in a rural area right now, so I was smiling in my head. I'm from a very rural part of Texas. Who does the education? I think that you do have an opportunity to do the education. If you know who their prescribers are in your local community, reaching out to them just in general to talk about what you provide. Just yesterday, I know some of my staff were taking the governor and some senators on a tour of recovery housing. I think that would be a great way of getting individuals, so you're not approaching them about a particular patient, but just talking to them in general about we both are supporting individuals with an opiate use disorder. Would you like to come visit, come have dinner or just take a tour and develop that kind of relationship? The first question, I would like a little clarification. I think you referred to it as the service, and I didn't quite catch what the service was. I don't know. Are you talking about recovery housing, or could you tell me more about your service?
Yeah. So I work through a nonprofit out here, and we're kind of like a resource hub. So we have 3 mentorship programs. One's a mamas, one's a reentry program, and then now we've been launched for about a year now, just over a year. It's called the rehousing program, but it's a recovery-based programming that offers supportive housing. So we're a level 1, so we don't specifically like administer or anything like that, but we do accept people who are on MAT services.
Wonderful,
And
wonderful.
yeah, and so and we've met a couple challenges here and there with it, and so it's been a little mixed reviews. But in my opinion, and being the program manager, of course, I promote it. I think it's a good thing, and I think it's saving lives, including mine.
Yeah.
It saved my life, and so.
Well, Ryan, with that, I mean, I think that's, we're talking about, how we know things as persons in recovery. You've got your lived experience, and I think, just approaching prescribers, with, professionally, ethically, and thinking about, ways that you can, educate and have them understand the recovery process, I think will go a long way. Best of luck to you, man.
Thank you. Yeah. So to clarify, you're saying get in there and just be a squeaky wheel.
Well,
and
I mean, sure, maybe
that.
squeaky wheel. How about the metaphor being a resource? Because the prescribers may not know what recovery is, and they may see people very early on in the process. They may not see individuals with long-term recovery, and so there's an opportunity for you to develop a relationship with them, and they're coming with that academic knowledge, that medical lens. You have an opportunity to give them a insight into a whole new world.
Thank you.
Yeah.
Thanks so much, Ryan. Question from Richard.
One, thanks for the kind words about the symposium, Jason. Yeah, it was great.
So I don't know how much of a question it is or how much of a comment it is, but you know, we're in such a time of change when we look at it's the acceptance of many pathways of recovery. So when we look at matter, we look at harm reduction, or we look at whatever pathway that might be, physical activity, fit to fitness, those types of things. We also need our recovery housing, at least in my honest, humble opinion, to match those pathways of recovery that are allowing for that. Whether it be, you know, we have co-occurring conditions is just a fact of life of where we are. When we talk about our population, or, you know, those of us in recovery, you know, is high. So being able to have housing that's safe in recovery environments. So I guess the question would be, do you see this moving forward in that way, or is it one step at a time? With let's focus on, you know, mood housing and Medicaid assisted, and slowly move into the others. I think as we, you know, our experiences tell us that that can be successful. But I think individuals with mental health conditions and various others need to be included. It needs to be more inclusive than it is exclusive. And so I just didn't want to, if maybe NAR and House Bill 299 is going to help with some of that. What your thoughts?
Yeah, I thanks for that. And there's a lot in there. So kind of unpacking that, I would say that I don't have the stats. I'm channeling Amy. I'm trying to channel you. I suspect that we would find that many, maybe most residents in recovery housing are dual diagnosis, dual recovery. I think the one thing that you talked about, many pathways, and there's kind of a modern phenomenon right now looking at defining harm reduction in the context of recovery, or recovery in the context of harm reduction. I think we're in a really interesting part of history where those kind of conversations are happening. I wonder whether there's some artificial pressures that is causing that, perhaps some scarcity. I personally hold the two separate. I think that there's value in holding the two separate. And when we look at individuals who have harm reduction goals, you know, perhaps housing first is the evidence-based program for them. Whereas individuals who have more abstinence goals, historically, that has been where recovery housing has fit in. And I think that we're going to have to wait and see how all this unfolds from you know, looking at you know, the articulation between harm reduction and abstinence-based recovery. Mental health only homes. I know that I have been in conversations. Historically, persons with mental health only have not had the best experiences in shared housing. Although there are some bright examples, there is some programs in Southern California that look a lot like Oxford houses or sober livings, but it's specifically for individuals in mental health recovery. And I've been trying to, I know that there's some research going on those particular homes or that particular model. I look forward to the papers coming out on that and us being able to highlight that to see if we can develop, you know, recovery housing, but for individuals that identify solely with mental health recovery.
If we can squeeze in one last question, Monica, let's go to you.
Hi, mine is more of a comment. So first of all, thank you for buying into this process of supporting individuals on medication-assisted treatment in recovery residences. I've been fighting this battle in Maryland for decades now, but it has come full circle as it is a requirement of recovery residences based on NAR standards to not discriminate against individuals on medication-assisted treatment. It is the responsibility of the recovery resident to work with the prescriber and keeping in mind the community that individuals may be engaged in housing services with people who are not on medication-assisted treatment, and being able to have a continuity of care with those who are in recovery residences, as well as the prescriber of those organizations, of those services. One of the things that we have been able to do is connect with more recovery-based organizations that buy into the fact that we're trying to support people all the way around with a continuity of care to be able to allow for individuals to recover and not perpetuate over medication, and being able to ensure that people are not medication seeking, and being able to speak with and to providers to say, hey, we know that they may have came to you and said that they are not feeling their medication or their medication isn't working. However, when they're here, they're incoherent. They're unable to function. We're afraid for their safety as they may be out on the street, going to different places, appointments or whatever, school, whatever, wherever they're going. But if every time they sit down, they're unconscious or, they're incoherent, that is a problem for us. And so we have providers that are more applicable to look at those aspects as opposed to just me trying to satisfy the participant or the resident to be able to say, I'm not, my medication isn't working anymore. So it's good to hear that not only is it being perpetuated here in Maryland, but it's going statewide, that we do have legislature and we do have adequate advocates to be able to speak to those things, to support us as we support individuals in being able to have sustained life changes in the community that allow for individuals to recover based on whatever pathway they choose.
Yeah, thank you for what you're doing. I think that you're part of a cohort of recovery housing providers that are really looking at how do we do this and how do we do it well. So thank you.
So with that, thank you so much, Monica. Thanks so much, Jason, for this incredible presentation and for answering these questions. I welcome anyone to drop any other questions you might have in the chat, and we'll try to get them answered after the webinar. And now I'll pass it over to Amy.
Wow, fantastic discussion. And thank you so much, Jason, not only for this webinar, but the 4 or 5 other webinars that you presented at. I just find it wonderful working with you, so inspiring. So there are so many challenges. There's so many barriers, but just in listening to you talk today about strategies and sharing information and all the ways that we can overcome those barriers, build those bridges, provide education. Again, yeah, just inspiring. Thank you so much. So let's switch gears a little bit and talk about what's coming down the road with the I-STARR project. So later this month, we'll have another webinar. This is a webinar in our researcher training series. It will be on multi-level modeling. We'll have Meena Subbaraman and Liz Mahoney presenting on that topic and providing examples from recovery housing research. And then in April, we have 2 webinars. And these webinars are going to be slightly different because we're drawing to the end of our training series. The provider webinar is actually going to be all about participating in research and collaborating with researchers. So all of the provider webinars heretofore have been hosted by or presented or had the presenters were folks with experience operating, supervising, managing recovery housing. And this is actually the first webinar that will have someone as a researcher, myself, we'll have Liz Mahoney back for that as well, talking about research. But we're doing this because we want to make sure that recovery residence operators are fully prepared to partner with researchers, that they're fully prepared to help their residents participate in research. So we're really excited about that. The other webinar that we're doing in April is the researcher training on the challenges of operating recovery housing. And that is actually, we're going to flip that up too. So heretofore, we've had researchers leading the researcher webinars. This time we're going to have some operators and managers talking about recovery housing, because again, if we're wanting researchers to step into this field, roll up their sleeves and do research on recovery housing, we want to make sure that they understand what recovery housing is and everything that's on the plate of the operator manager when they're inviting someone to collaborate with them in the research process. So I'm really excited about those webinars. I think that if you're here at this webinar, both might be fun for you to sit in on. So that is our I-STARR activities. I also want to mention the National Conference on Addiction Recovery Science, the NCARS conference. That is going to be in April, the 24th and the 25th, and we can drop a link to where you can register for that. If you register by the end of the week for the conference, you can get a discounted registration fee for that. And with the 2 minutes that we have left, I also want to talk about or have someone talk about one of the I-STARR pilot studies that we're running as part of the I-STARR project. So Rashmi, if you're available, do you want to say something about the status of the Mo I-STARR project?
Yeah, of course. Thank you so much, Dr. Miracle, for that introduction. So essentially, the Mo I-STARR project, what we're hoping to do is essentially observe what are some attitudinal and or capacity barriers toward implementing MAT in recovery housing. So I don't know how many slides are in this set, but I did drop our information in the chat earlier. We are currently looking for about 750 total participants. The way our recruitment is set up, operators for each individual recovery house have to take the survey first. Unfortunately, the survey on that slide set is no longer valid. However, the link to the survey that I put in the group chat is one that you all can take and access. And after receiving the link and passing the screener and completing the survey, operators will receive an email with a unique survey link for their residents to fill out. Up to 10 of the residents in their recovery home can fill those surveys out, after which residents can complete the Mo I-STARR survey. And hopefully we'll be able to get some results as to what are some barriers towards implementing and or supporting MAT in recovery housing. So that is the study that we're hoping to collect data on. We'll be collecting data through the end of March. However, we will probably be closing towards the end of March, beginning of April. Please contact us at moistar@umsl.edu if you have any questions whatsoever. I'm the person monitoring that email, so you'll probably hear back from me. And please let me know if you have any questions. Thank you.
Excellent. Thank you, Rashmi. Really excited about the Mo I-STARR project because it's very germane to everything that we were talking about today. And so hopefully folks will be able to get in touch with Rashmi and participate in that study. So let's go to the next slide. Just want to remind folks that we are recording this webinar. It's one of 12 in a whole training series. You can, if you attend all 12, you can get a certificate. And you can also earn CEU credits. And the way we track participation, we are tracking folks who show up live, but we can also track participation through our learning management system. So if you've missed a webinar, you want to get the certificate, get the CEUs, make sure that you are viewing the webinars through our learning management system. So let's go to the next slide. I think this is a wrap. So thank you, Jason. Thank you, everyone who was attending. This is just a treat to do these webinars each month, and hopefully we'll get to see you back next month for a webinar. Take care.
Thank you.